Bismillahirrahmanirrahim. Assalamualaikum and a very good morning to all the participants. Okay, today me, GY, will be your MC for the full day event of the 9th Asia Pacific International Conference on Quality of Life, AMER's 51st International Conference. Assalamualaikum and a very good morning to the distinguished AMER President, the Conference Chair, the AMER Board members, the International Breakout Chairs, the International Scientific Committee and all editorial team, professors, doctors, paper presenters, and also participants. Ladies and gentlemen, the opening ceremony will commence now. Please stand for the national anthem. Thank you. All please sit. Okay, we now call upon the conference co-chair, Professor Dr. Masa Suhono, for the pay recital. Prof, over to you.
Assalamualaikum warahmatullahi wabarakatuh. A'udzu billahi minasyaitonir rajim. Bismillahirrahmanirrahim. Alhamdulillahirabbil alamin. Hamdan syakirin. Hamdan yafi nakafi mazidah. Ya Rabbana lakal hamdu kama yanbaghi li jalali wajhil karimi wa azimi sultani. Ya Allah, ya Tuhan kami, segala puji hanya bagi-Mu ya Allah, Tuhan semesta alam. Kepadamu kami berserah dan kepadamu jualah kami memohon perlindungan. Selawat dan salam ke atas Nabi junjungan besar Nabi Muhammad SAW, kepada keluarga beliau, para sahabat dan tabi'in. Engkau lapangkanlah hati kami, Kau satukanlah hati-hati kami. Kau berkatilah perhimpunan kami pada hari ini ya Allah. Semoga ianya diterima sebagai satu perhimpunan yang hanya mengharapkan keridaan-Mu ya Allah. Kau pandanglah kepada usaha kami yang kerja ini melalui AQoL 2025 Cherating, wadah sebagai satu usaha yang mulia di sisi-Mu. Kau kurniakanlah perjumpaan ini dengan bimbingan yang berterusan ya Allah. Bantukanlah kami, bimbinglah kami untuk menerus ke alam ciptaan-Mu yang amat luas demi ke arah kebaikan, kelestarian dan kemakmuran manusia sejagat. Kau permudahkan untuk kami terus menjalankan aktiviti penyelidikan di muka bumi-Mu dan menyebarkan hasil dapatan dalam konferensi yang sedang berlangsung ini dan yang dirancang di masa hadapan. Kau berkatilah usaha kami dan bantulah kami untuk tidak sedikit pun mengabaikan tanggungjawab sebagai khalifah di muka bumi. Rabbana azwajina wa dzurriyyatina qurrata a'yun waj'alna muttaqina imama. Allahumma ighfir lana dzunubana wa liwalidayya warhamhum kama rabbayana shaghira. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina adzabannar. Subhana rabbika rabbil izzati amma yasifun wa salamun alal mursalin walhamdulillahi rabbil alamin. Wassalam. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Thank you so much, Prof. Ladies and gentlemen, Syukur, we are indebted to the Almighty for the success in organizing this AMER's 51st International Conference, and we pray for the smooth running of today's event, hopefully without any hitches. I will now briefly summarize the activities as per today's updated program. Before that, kindly note the program booklet distributed was published March. Earlier, several adjustments and amendments to the program have to be made since the participants should refer to the latest updated program as per even most recently. Please refer to it. Okay, to continue with the opening ceremony, welcoming speeches will be delivered by the Prof's chair. This will be followed by the opening speech and subsequently the officiating of today's event. After the opening ceremony will be breakout 1. That will be followed by the group photo, which will be outside the building before we have our lunch next door. And for breakout 2, will commence after lunch at 2 p.m. and breakout 3 will commence at 4:15 p.m. after tea break. There will be a short break after breakout 3 and dinner will be served at 7 p.m. next door. So far, do you guys understand? Yes? So ladies and gentlemen, without much further ado, we call upon the conference chair, Dr. Muhammad Yusuf Hafaz, for a welcoming speech. Dr. Yusuf, please.
Assalamualaikum. Alhamdulillah, thank you very much for your attendance today. I see some familiar faces and some for followers as well as newbies. Thank you very much. To be here again. When I say again, we were here actually I think about 2 years ago. So we like this place and we would like you to enjoy this place. So we are really again here. Hope you had a comfortable journey. Some have checked in here and some might have checked in outside because actually in particular today is actually full house. Okay? In fact, some of those who block booking with us have to upgrade their rooms because when we submitted our rooming list, all were full up and most, in fact, all of them have to upgrade. So very sorry about the inconvenience. Okay? Now, I'll talk in much detail during the post-conference, okay? Because for today, it's a bit of a rush. Just in mind that it's very important for you to attend the post-conference, because it is your last testing, last chance not to be surcharged. Okay? As you're aware, we do it paper by paper, one-to-one. We do it slowly, one-to-one. The idea is so that all of you comply. Yeah? But then again, based on the last conference in London, many surcharged because many did not attend. Many did not attend and they did not go through the tutorial. Okay? We cannot help you if you do not want to help yourself. Okay? So we've given you ample portions and this is your last final chance not to be certain. Okay? Right. For today, MC have actually briefed you on the activities for today. So basically it's very convenient, everything is within here, right? So again, okay, regarding the papers review, actually email to all of you, all the reviews. It's quite common that they'll be to settle the point. Yeah, one giving you 0, one giving you 5. Okay, so when we receive the reviews, we have to moderate to be fair. To be fair, as you're aware, the editorial team, yeah, they have different levels and knowledge and background, and they are multi-versatile in a way. But then again, the way that you submitted your paper, the understanding could be transmitted or transferred into various dimensions. Yeah. In particular, to those who do not follow accordingly the structure, you can be the best paper, or if you just follow through the guideline. It is an open book. The answers are there, but yet again some did not. Okay, I do not know why. Because, for example, there are what 8 sections, I think, yeah. And some of you just didn't fill in the blanks, so you go 0. But then again, the moderating bit is that, as you're aware, editorial team members are human beings. They have different, like say, they have different backgrounds and so on, different understanding. If you write it a simple, straightforward statements, it's quite easy to give the marks, right? But if you keep on like the Hindustan movie, yeah, around the coconut tree, and then going to your points, you know, some might capture, but if you're unlucky, some I still follow you around the coconut tree. You know what I mean? So it's best that for a proceeding paper, just fill in the blank by being direct. For example, what is the aim? The aim is the objectives are so when the reviewer mark your thing, it is already there. They do not, follow you still, around spinning around the coconut tree. You know what I mean? Some of you are novelists, novel writers actually. I mean, you have the flair to write novels, yeah? But when it comes to writing papers for the conference, I think you've got a problem, yeah? You've got a problem. It's nice to read, but then again, you really need to dig, it's actually behind. You don't miss the woods for the forest or miss the forest, or something like that. Okay? Anyway, the idea is write simple. Just write simple and straightforward. Not nothing for it. Okay. So more of this thing I like to say during the post-conference. Please do attend. I'm going on this Wednesday. Yeah, 8 o'clock Malaysian time. Yeah. So please be there. And for today, hope you enjoy the conference. Yeah. And just some last words. Our strategy now is actually to organize the conference during the public holidays or school holidays, because many have families and they have to take their family for their holidays. So we'll try to do that for 2026. And on the 2nd of January, Punya January is going to be in Jakarta. 2nd January, our Kota Desert. Okay, for today, thank you very much.
Okay, thank you, Dr. Yusof. Okay, now we will call upon the distinguished Army President, Assistant Prof. Dr. Mana Shah, for her opening speech, and also subsequently to officiate the 9th AQoL2025Cherating. Prof. Ana, the floor is yours.
Thank you, Adik. Bismillahirrahmanirrahim. Rabbi shrahli sadri wa yassir li amri wa hlul 'uqdatam min lisani yafqahu qawli. Qawlu amri ila Allah innahu basirun bil ibad. AMER Conference Chair yang berbahagia Profesor Dr. Muhammad Yusuf Abbas, International Scientific Committee members, editorial team, professors, doctor, conference participants, ladies and gentlemen. Assalamualaikum and a very good morning from Cherating. How are you? Yeah, I just recovered from still coughing. So no karaoke today. I was going to skip that. I think most of us are being affected by influenza, hitting schools and universities, but all of you are still here. Congratulations, means you are fit to be in this conference. And it is with a great pleasure and excitement that I welcome you again to our 9th Asia Pacific International Conference, Quality of Life AQoL being held in Holiday Villa Beach Resort and Spa Cherating. So this time around, we actually managed to get 36 numbers of approved abstract. So one of the remarkable aspects of this conference is the international collaboration it has fostered. So authors from 11 countries has contributed with a significant numbers of abstract being in partnership with Malaysian authors. Congratulations to all of you. Indonesia for this time around leads the collaboration with 50% joint abstracts, and followed by China with 8 and Jordan and Nigeria too. Additionally, we have contribution from Algeria, France, South Korea, Maldives, Saudi Arabia, United Kingdom, showcasing the diverse and global nature of our research community. So from the approved abstract, we have proudly announced the 32 full papers have been transformed, making an impressive return of 89%. So these papers are grouped into 14 subcategories, reflecting the diverse range of environment studies that you all have undertaken. So the top 3 categories in all the priorities are health and healing environment with 9 papers, education learning environment with 8 papers, and this conference is actually a testament to the dedication and passion from each and every one of you. I think to travel here is not easy for all of you, right? We have our sacrifice that we made. Some of you had managed to stay here, some stay far, and we have to think of our logistics to be here. for this conference. So I would like to extend my congratulations to all participants again and my heartfelt gratitude to all the crews, speakers, volunteers, organizers who have dedicated their time and resources to make this event possible. So with Bismillahirrahmanirrahim, I declare AQoL 2025 Cherating. Thank you so much.
Thank you, Prof. Our President from Paris. Okay, so basically, the original plan was after the recitation, we would our coffee stay away, but somehow it's a bit late, so we are changing a bit for the coffee time. As we enjoy the presentation while enjoying coffee at the same time.
So breakout follow the time because Nigeria is making like that.
Okay, so basically, for breakout one, Prof. Babatunde Emmanuel Jaiyeoba from Nigeria will chair the breakout one session. Okay, I don't think he's in yet.
Yeah, okay. So we just.
So, but while we're waiting for him, to come to join, we will have our coffee now. I think it's ready. So yeah, let's go for coffee now.
All right, good morning. If we are set, you're welcome to this breakout session.
Okay, yes, thank you for Babatunde. Yeah, are you ready, Prof?
Yes, I'm ready.
Okay, I almost forgot before we start. Please be advised to silence your phone. And if you want to talk to the person beside you, keep it at a minimum volume so that it won't interfere with the sound from the carrier recording during the presentation. And also those who are here who doesn't have this, which is the text, cannot come in here. And also, if you guys don't have this, you guys can't come into the network. That's right. So, does anyone understand? Yes? Anyone understand? Yes. Okay, so for the presentation, don't worry, for the slides, I will open the slide, and I will give you the laser pointer. Yes. So it's easier. Okay, so let us start with the first presenter.
All right, thank you. You're welcome to this breakout one on Saturday on the 9th Asia Pacific Conference, International Conference on Quality of Life. So if we have participants, our first presentation is on early mobilization practices amongst ICU nurses, a scoping review of influencing factors. Is Sabrina there? All right, thank you. Do you have your international collaboration online? The international collaborator. That's Rukaya Zubai Abubakar. Is she online or present at the conference? Yes, you can. You have 10 minutes.
Thank you, Prof. Thank you, the chairperson, Professor Doctor. Assalamualaikum and very good morning to all these distinguished colleagues, presenter, participant, and ladies and gentlemen. It is an honor to be present at the 9th ASEAN Pacific International Conference on Quality of Life. My topic today is early mobilization practices among intensive care, among ICU nurses, a scoping review of influential care. This study was conducted with my supervisor, Dr. Zamzaliza Abdul Mulud, Nurfita Muhammad, and also Rukaya Zubair Abubakar. Before we go further to the next session, let me introduce the background of my study. Okay, for the background, patients admitted to the ICU often experience long periods of immobility due to the severity of their illness and also dependence of life support. First 24 hours of admission to the ICU is the crucial time to start an early mobilization to patient. Early mobilization, however, is proven to bring many advantages to the patient. It will shorten ICU stay, prevent complications such as muscle weakness, and improve overall recovery to the quality of patient life. Despite this benefit, implementation of early mobilization remains a challenge. Many ICU face barriers like insufficient training, shortage of staff, unclear protocol, and safety concerns. These challenges highlight the need to understand the factors influencing early mobilization practices among ICU nurses. Okay, this review aims to explore the factors influencing ICU nurses' early mobilization practices. And we focus on three objectives. The first one is to identify the current evidence available in the literature. Second one, to examine the both barrier and facilitator that affect implementation of the early mobilization. And the third one, to recommend strategy that can strengthen future practice and policy of early mobilization practice. Okay, for the literature review, this study, literature review constantly highlights three major areas. The first one, the benefit. June Lee 2024 mentioned that early mobilization reduces ICU stay, prevent complication, and enhance physical recovery. And second area, we focus to the barriers. Knowledge gap, safety concern, and limited staffing often hinder the implementation of early mobilization. And finally, the facilitator factor, the presence of structure, protocol, teamwork, and staff education have been shown to support consistent practice. Changwan King 2018 state barriers that hinder the early mobilization practice are excessive workload, inadequate staff, inadequate training, and also absence of protocol. Okay, now we go to the methodology. This study followed the preferred reporting item for systemic review and meta-analysis extension framework, which is to ensure a transparent and systemic approach. We searched four major databases, PubMed, SINA, and ScienDirect for studies published between 2015 to 2025. After screening 750 articles, 25 articles met the inclusion criteria and were included in this review. For studies that only solely focus on the physiotherapists, physicians, and other healthcare workers that not involved without involvement of the nurses were excluded from this review, and also study that not done in the ICU. Okay, for the findings, our findings reveal four key influencing factors. The first one, incomplete understanding of staff mobilization criteria, which is knowledge remain nurses. Many nurses are unsure about when and how mobilization can be safely initiated. And the second one, heavy workload limits time for immobilization, which is challenges of staffing and workload challenges often limit the time and manpower available to assist patients to perform the early mobility activities. And the third one, absence of clear standard mobilization protocol, which is many ICU lack clear protocol which lead to inconsistent practice. And the last one, fear of patient instability or adverse event. As we know, patient admitted to ICU, it was very critically ill, and patient lot of tube drainage devices access to their body. That's why from that also will occur the threatened from the nurses to perform the early mobilization to the patient. Okay, for the next slide, for the discussion, the findings of this review are consistent with international literature, which is the same barriers appear repeatedly across ICU settings worldwide. Education and structure protocol are vital to enhance nurses' confidence and standardized practice. Teamwork between nurses, physiotherapists, physicians is equally important, as early mobilization is a multidisciplinary effort. Lastly, sustained change requires leadership and organization support. Without that, improvements are often left a short line. For the conclusion, early mobilization is essential for recovery in critically ill patients. Sustainable changes require nurses' empowerment, education, and institutional support. Future efforts should focus on standardized guidelines and STEAM-based approaches. To conclude, early mobilization should not be seen as an optional intervention. It is a fundamental part of quality ICU care. Our review emphasized that change must start with empowering nurses through education, teamwork, and structure protocol. Looking ahead, we recommend that hospitals adopt clear guidelines and interprofessional collaboration to make early mobilization consistent, safe, and sustainable practice. Early mobilization is more than a clinical intervention. It is a vital part of holistic patient-centered care in the ICU. Our review has shown that while the benefits are clear, challenges such as knowledge gap, workload, safety concern, and lack of protocol continue to limit consistency of the practice. But this barrier can be overcome through education, teamwork, and strong international support. Last but not least, together we can transform early mobilization from an occasional effort into a standard, sustainable practice in every ICU. With that, thank you very much for your attention.
All right. Thank you very much for that presentation that took exactly 10 minutes. I'd like to ask whether our participants have questions for Sabrina and the collaborators. Okay. Let me ask the first one. I know that this is a scoping review, and part of your findings talks about when to mobilize the patient. I just want to ask, how do you determine that the patient is ready for mobilization? Can you hear me?
No, please repeat, Prof. I can get it. I can't get it.
Okay, what I asked is, how do you determine that a patient is ready for mobilization?
Okay. For the ICU patient, first 24 hours of mission is a crucial time, but we have to do the assessment to the patient, which is they can be moved or not. Like patient on cerebral support for neuro injury, cerebral protection should be for 48 hours. But within that, we also we can perform the passive movement, which is the 4 limbs passive exercise, with the permission and the suggestion by the clinician that take care of the patient. But we must do the assessment first.
Okay, thank you. And then now that you have done a scoping review, what is going to be your next line of research? Is it going to be in relation to this topic? Or what do you want to do with the scoping review now?
But I want to do the scoping review. If I can, I can produce my finding to the firstly for my department of anesthesiology at my hospital. Then I hope we can discuss about to create a guideline or policy to benefit our nurses to perform the early mobility safely to the patient. It will improve, it will it will give the benefit to the patient. It will recovery early to get quality of life after transfer to general ward.
All right, it will contribute. You are saying that it will contribute to the practice of nursing in your various hospitals with the findings. All right, thank you very much. From the participants, do you have any other contributions on this topic of early mobilization practices amongst ICU nurses? If there's no other one, let's appreciate this presentation with a clapping that they have done well. All right. Let's get ready for the second presentation then, which is on mental health seeking barriers among young adults in tertiary education in Malaysia. Is your collaborator from Indonesia online or present at the conference? Your collaborator from Indonesia?
No.
Okay, no, all right.
You
So,
know my collaboration with Rizky Fitiasari, is it? She not.
yes, you can start.
Assalamualaikum and good morning to the chairperson, professors, doctors, and all the participants in this talk. Today I would like to present my research work, which titled Mental Health Seeking Barrier Among Young Adults in Tertiary Education. Standing here, I'm Nur Masya, the representative of my co-author, Dr. Zamzalita from UITM, and then Dr. Rizky Fitiasari from Faculty of Nursing, Universitas Airlangga, Surabaya. Today I will briefly explain what our research do, our finding, and what it can contribute to society as a whole. Depression is a growing global issue, and young adults represent a particularly risky group. As you can see from the data Institute of Public Health recently, 2003, twofold increase or 1 million Malaysians aged between 16 years and above have depression symptoms. And then this is because they are, and for the young adult, is quite high. 30% to 50% young adults in public university experience depression. This is because they are going through major life transitions between adolescent and full adult, and they require to be full independent. And then there are many challenges they face, such as academic challenge, identity development, and social adjustment. Depression are important problem to tackle, especially by KKM. This is because it was linked to various adverse consequences, such as poor academic performance, social withdrawal, and functional impairment. And more finally, it was associated with suicidal behavior. And interestingly, despite increasing efficient intervention for the patient, many of the young adults still prefer seeking help from informal sources such as family, rather than consulting professional mental health service, such as counselors, psychologists, and psychiatrists. This highlights the gap in mental health seeking behavior which need to be tackled. For this purpose, the study objective to explore the barrier of young adults with depression symptoms to seek for professional mental health support in public university. Mental health seeking is a dynamic process. It involves self-identification of the problem, forming an intention to seek the mental health professional, and subsequently actual behavior of health seeking. It was not a straightforward process. There are obstacles along the way of the health seeking. And perceived barriers are among the reasons why individuals with depressive symptoms avoid seeking formal mental health support. Unlike physical disease, mental health problems are more subjective to the participant. It's only influenced by individual awareness of their own symptoms, which is crucial in the earlier process of recognizing mental health problems. And help seeking for professional for mental health issues require a positive individual attitude, perceived approval, and high efficacy in executing such behavior, which were explained by theory of planned behavior. The methodology for my research is we are using phenomenological qualitative study by in-depth interview data collection using purposive sampling and online Zoom meeting in the public university in UITM, Puncak Alam. Sample was aged 18 to 85 years old, studied full time, and then before we select the participant, we screen the patient, which is depressive score. We select the participant with depressive score 10 and above on patient type questionnaire, PH9. And then data analysis, we are using reflective thematic analysis for development of team. Okay, our finding from 11 participants, we go to in the interview and to reflective thematic analysis, we found 6 significant themes emerged from the data, which are: first, expression problem, attitude, fear, presence of attitude, alternative support, mental health literacy, and instrumental barrier. Expression problem, emotional validation, which they report they do not receive. Emotional validation, which makes it difficult for them to recognize their symptoms as acceptable in order to seek help from mental health professionals. They also verbalize that some of their close ones, especially from their friends and family, they do not trust they have a mental health issue, and they tend to believe that participants just, what. And then the second one is attitude, which the starting is perceived severity. The participant believe their problems are not serious enough to be seen by a mental health professional. They believe that emotional problems just as normal being as a student. They also prefer for self-reliance for the solution, and then the poor attitude toward the mental health professional itself. And then they also report the fear, which include fear of shame to the themselves and then to the especially for their family. And then some of the participants expressing fear of their data being leaked, and then reduce the chances for them to get a job in the future. And then the presence of alternative support with they more people to reach out the close relationship first. Means like friends and family. And then the convenient to get, such as the friends. And then mental health literacy, with especially in recognizing their symptoms. And then procedure to see mental health professional. And then as well, the last one is instrumental barrier, which is time restriction. They must divide the time for academic, and then how to see the mental health professional. And then, of course, difficult to assess. They perceive that they very difficult to assess the mental health professional.
The moment we have 2 minutes more.
Okay. Yeah. Okay. In our study, two main factors emerge as significant explanation for help-seeking behavior among young adults, which are lack of self-awareness and perceived as poor self-efficacy. First, the lack of self-awareness refers to young adults' limited ability to recognize their own emotional symptoms as early symptoms of mental health problem. From the data, the themes such as expression problem, attitude, mental health literacy are the clue that explain participant lack of awareness. And then secondly, perceived poor efficacy reflect a lack of confidence in one's ability to seek and manage for their professional effectively, which reflect participant barrier found in this study, which are present of alternative support, instrumental barrier, fear, and attitude. The two significant factors is explain how social stigma, social support, and mental health knowledge influence young adults for seeking help from professionals. For example, when mental illness is stigmatized, individuals tend to avoid labeling their experience as a psychological problem, and then leading to either recognition and delay help seeking. Others, those with limited social support, often feel isolated and powerless, while stigma reduces their belief that reach out with will be met with understanding or acceptance. Okay. For the conclusion, this finding highlight the role of self-recognition of depression symptom and self-efficacy, and then social stigma, mental health literacy, and perceived social support are among the factors which indirectly influence help-seeking behavior for professional health. Then for our study, the recommendation is intervention promoting the use of professional mental health service should be tailored to enhance awareness and recognition of depression symptoms first. And then the secondly, intervention can focus on establishing support systems that encourage and facilitate young adult engagement with mental health professionals. That's all for me. Thank you.
All right, thank you very much for that presentation on mental health seeking barriers among young adults. And do we have any contributions or questions for them on this research? Is there someone there? All right, if there's no immediate reaction, your background says that oh, there's a question.
Yes.
Okay, thank you.
So much. This is a question. Your topic is very interesting. I'm asking this question not to pressure you mentally. Okay. Please. how do you collect your data? Because this is, I think, what is happening in Malaysia nowadays is much related to mental health issues and so on. So when it comes to recommendations, right? First, my question is how you collect your data, all right? Your respondent size and so on. Secondly, is your recommendation, with your research, how can you reach the public effectively? Because in order to create the awareness among the public is not easy. Even among ourselves, if we ask this question, we do not know how to recognize whether we are having mental health issue or not. This is something really, really important, and it's very difficult for us ourselves to go and tell you we have mental health issue. Please help me. That is a very, very difficult statement for me. So my question is, again, how do you collect the data and how do you recommend your recommendation to reach the large society? Thank you.
Thank you, sir.
Okay, thank you.
For the first question, how I collect. Actually, this is phase 2 of the study. My study was titled Depression, Determinant of Depression and Mental Health Seeking Behavior Among Young Adults. Actually, the participant is we select from the phase 1 of study, which are around 379 participants. And then this is phase 1, phase 2. Okay. I choose when they miss the PHQ-9. PHQ-9 is for depression screening, which are above 10. That's the way we call the participant, we email if they were interested to join the view. I mean the phase 2 study. And then second question. This is I think it is quite difficult for us to explain, to tell the public that you have a mental health problem. But the simple intervention such as screening, and then you meet them face to face and tell them this is your result. For example, you got 12 on PHQ-9, and then this will be a mental health issue. Then even from my experience doing an interview, they think that when they doing the screening, I mean the doing yeah, they do not know they have a mental health problem. They deny. No, they deny, and then they think that it's normal. After we telling them it's not normal. Because the first more important finding from my qualitative study is emotional validation. It's hard for Malaysians, especially young adults, to believe that they have mental health issue. Otherwise, someone tell that you have a mental health issue. They need emotional validation.
All right, so you are saying that the participants are volunteers. They volunteer to be part of the study. And then you have to carry out assessment in order to really find out whether they have a mental health problem. Now, I have one direct question. Why is there an increasing rate of mental health issues among young adults?
Sorry, folks, I can hear.
You cannot hear.
Can we repeat again your question?
My question is that why is there an increasing rate of mental health issues among young adults?
My research did not approach the real factors from the phase 1 study is the stress. The most significant factor that influence stress, academic, and stress. We have three determinants on my study: social determinant, that determinant, I mean the resilience, and then the stress. And then the most significant factor that influence stress, depression are stress. The students are stressed, and everyone is stressed in the university.
All right, thank you very much for that interesting presentation on mental health. So let's take the next presentation then. So we look forward to seeing you at the next conference. So paper number 3 is on occupational therapy in sleep assessment, tools for mental health, a scoping review.
Why? Okay, the secretary from okay.
Do you have your Indonesian collaborator online or present?
Yes, sir.
Present.
Yes, present.
Okay, wonderful. I hope there will be co-presentation. Are you the only one presenting?
I'm going to first present the first slide. The second to fourth will be my partner, and then back to me.
All right, that's wonderful. You have 10 minutes.
Okay. Assalamualaikum, I'm good morning for all. My name is Nova Aina. I'm from USDF. Today with my co-author, Associate Professor Hidayat Shahid from Indonesia. We are pleased to present our paper titled Occupational Therapy in Sleep Assessment for Mental Health, a scoping review. Now the slide will be given to my partner first, and then I'll be back to that.
Okay, yeah, thank you, Farah. Can you hear my voice clearly?
Yes, we can hear you clearly.
Okay, thank you. So I will start for the background of the study. Yeah, based on the OTPF4 or Occupational Therapy Practice and Framework for Addiction, sleep is recognized as one of the occupation that support health and daily functioning. And then when sleep is disrupted, it can impact psychological symptoms and then affect emotional regulation and also reduce occupational performance. Even though occupational therapy is usually already doing treatment on holistic view of health, but the use of sleep assessment tools in mental health practice is unclear and still inconsistent. So the purpose of this review was to explore how occupational therapists are using sleep assessment tools for people with mental health condition, including exploring about what kind of tools that are being used and how are integrated into intervention and what evidence gap still exists. Okay, now next slide, please. Okay, this is the methodology of this study. Yeah, we already doing this flow chart, and for the review, we use the AMER framework and also followed by PRISMA guideline for scoping review, and we search using PubMed database, Scopus, and also Web of Science, and yeah. We including studies with OT intervention that use at least one sleep assessment tool for adolescents or adults with mental health condition. And in short, from all of the database, only 5 studies meet all of the criteria. And yeah, this is very limited evidence, but by doing this study, it's kind of a promising and growing area of occupational therapy practice. Okay, next, please. Okay, this is the summary of those 5 studies that we already do. The first one is by audience in 2023 found that weighted blankets were helpful for people with dementia, anxiety, and also autism. And this is were costly than medication. And then still by audience in 2025 point out that there's still a lack of OT-specific sleep tools. And Ekman in 2022 showed that the REST program is a kind of CBT for insomnia, improve sleep and participant. And Angie in 2020 found that meaningful physical activity like soccer and then Tai Chi able to improve both sleep and mental health. And the last one is Kawatsu in 2024, so that such program is kind of culturally adapted CBT, Japanese CBT, I think, able to improve sleep, anxiety, and also depression among students. And overall, these studies highlight that OT sleep intervention can be effective. But our finding is we still need standardized tools to strengthen practice and also research in this field. And the next explanation will be going to Farah again. The time is yours, Farah.
Yeah, I'm back. Thank you to my partner. We are going to continue to the sleep assessment tool use. The tools identified in the study are diverse, subjective such as critical sleep quality index, which we call it SQI, the insomnia severity index, and daily sleep diary were most commonly used. Only one study an objective measure, which is the actigraphy. Some studies integrate mental health specific adaptations such as the PTSD addendum to the PSQI. However, there's no standardized or occupational specific sleep assessment tool was identified, represent a critical gap of practice. Okay. These tools were applied in a different way. In a CBTI, or we call it Cognitive Behaviour Therapy in Insomnia program, such as LEAS, WES, and SHIRS, sleep diaries are informed individual sleep prescription. In activity-based intervention, the PSQI was linked to a broader measure of health and participation. In contrast, sensory-based interventions such as weighted blanket rely more on registration data rather than occupation-centered assessment. This example highlights both the strength and the inconsistency of how occupational therapy currently integrates sleep assessment tools. The overall findings are encouraging. Across the study, OT-linked intervention consistently improves sleep quality, reduce insomnia severity, and enhance mental health outcomes. Importantly, some interventions also demonstrate improvement in occupational participation, underscoring the unique value of occupational therapy, including the domain of sleep and daily function. Despite this promising result, several evidence gaps are evident. There remain no standardized OT-specific tools for sleep assessment. Most studies only evaluate short-term outcome, with a predominance of Western adult participants. Finally, the economic evaluation was scarce, although preliminary findings suggest potential cost effectiveness of OT-linked intervention. These findings point to important implication. Research must prioritize the development of validated OT-specific sleep assessment tools. Clinicals should adopt evidence-based occupation-centered models such as CBTI and activity participant program. At the policy level, professional bodies must advocate for occupational therapy inclusion in sleep health guidelines, supported by the cost-effectiveness data to ensure sustainability and recognition. As a conclusion, occupational therapy has significant
potential to address sleep disturbance within mental health care. With current tools offer some utility, they remain insufficiently occasional focus. Future effort should emphasize tool standardization, culturally adapted models, and longitudinal trial. By doing so, occupational therapy can further solidify its roles in enhancing participation, recovery, and overall quality of life. Thank you. Thank you.
All right, thank you very much for that presentation that took just 10 minutes on time. And it's good to have your international collaborator co-present with you, which is really what is very interesting about the presentation. Do we have any questions or contributions?
Yes. Okay, can I have a question? Just a question. Meaning, if you have a sleep disturbance, it shows that you have a mental disturbance. For example, if you sleep late or very difficult to sleep, is it shows that you
sleep disturbance with mental health? Sometimes it's called awake, sometimes it's not. Sometimes because we have to know the core issue of the sleep first. Is it because of we tired? Are we overly tired? Is it like, for example, today maybe we go marathon. Sometimes some people are very tired, they cannot sleep. That kind of thing is not involved mental health.
But without a reason?
Without a reason, usually involve mental health. Or maybe their own habit or daily life activities. For example, some for people who have shift schedule. For example, like staff nurse, they have a shift, right? Usually they have a sleep disturbance because they have to adapt change of time of sleep.
Okay, so basically,
all right, you want to add something? Yeah, is there a question?
Yes, I have a question.
All right.
Okay, if you have insomnia, is it basically, is it psychological, it's all in your head, or there's a different reason?
Okay, is I have to know the cause of problem of the sleep first. Sometimes because of medication, sometimes because of lifestyle, sometimes because of stress. We have to know we have to do the screening first.
Okay, talking about screen, they say that if you sit in front of a monitor or your phone, it will be hard, it will be difficult for you to sleep.
Certain studies that show we might have a difficult of sleep because of the blue wave from the tab or phone.
Okay.
Which kind of disturb our sleep. That's under the habit or our lifestyle that might cause of our sleep disturbance.
So it doesn't relate with PTSD or mental health, right?
If they have, they might be disturbed. But if they doesn't have, then it's our habit that we need to change. We have a certain, for example, like PSQI. That one is one of the screening we can identify we have sleep.
Okay. Sounds good. Okay.
All right, thank you for those questions. I just have one question for the presenters. By the time your criteria for selection was done, for assessing for these tools, you had only 5 papers left. I hope this limitation was acknowledged. Or is there a way that you could have had more papers, in the inclusive criteria for the scoping review? Is that a limitation, or is it okay?
I can answer that. First of all, the small study really reflects how emerging of this area for occupational therapy research is. Our OT, one of our main domain in our OT domain is sleep. However, there's a very limited research regarding of participant OT in the handling sleep case, even in Malaysia and worldwide. So one of the reasons is that because one of our inclusion is must include OT lead or OT focused intervention in our inclusion.
So it was your condition that that already caused the reduced number of papers. That all right. Thank you very much for that.
Paper on sleep therapy, tools that
we hope that you make some progress in devising more tools, since they are now really limited, for the ones that are culturally responsive, you say. So we'll be looking forward to your development of tools for sleep therapy. And we look forward to seeing you at the next conference. So let's take the next presentation. That's on advancing quality of life through thalassemia awareness with Thalia. And do we have the international collaborator present? Are you the only one presenting? Or do you have your international collaborator presenting with you?
No, I don't. Sorry, Prof.
Okay.
Can I start?
And is your international collaborator online?
No.
Okay. All right. You have 10 minutes.
Right. Assalamu alaikum and good morning, ladies and gentlemen. My name is Maisara, and we, the public health team from UITM Sungai Buloh and also the Mataram University of Indonesia, are very thrilled to introduce you to Thalia, a kit that teaches teens on how to outsmart genetics. Okay, so Thalia is short for Thalassemia Education and Awareness. Okay, so when we talk about education and awareness, it's lacking in our country in so much ways or another, especially on thalassemia. Okay, thalassemia is a genetic disorder of the blood. Okay, not many people know about it. Not many young people know about it. Okay, so before we start, I'd like to give you something to ponder upon. Okay. What can the government of Malaysia do with 3 million ringgit? Right. So one would say maybe we could actually support a family whose pay grade is below the P40 line for the length of 30 years. Some mothers might say that I'd like to install air conditioning in public schools for the comfort of my children for good quality education. Some people who are very enthusiastic about the environment might say we should invest in some good green technology for the betterment of the environment. But the government of Malaysia has other responsibilities. Okay, they have to use that 3 million ringgit to actually support or sponsor the treatment of a thalassemia major patient until their maximum life expectancy is 60 years of age. So 3 million ringgit is used for that. We could use that money for other things, but the government of Malaysia has that responsibility to shoulder on. Okay, so when we talk about quality of life, okay, most people would say my quality of life is through my wealth, through my good job, the comfort of my home, a good family. But what people fail to realize is that the foundation of quality of life itself is health. It's like building a house, right? When you build a house, you should have a roof, right? So the roof might be your wealth or your job, good job. And the walls could be some sort of happiness or family completion or your comfort in working at your office. But then again, the foundation of the house itself, the steel, the bricks, is actually health. Okay, so when there's a crack in that foundation, everything else will start to crumble as well. So health is really important. So how do we put in thalassemia inside this quality of life? How does it fit in? Okay, so thalassemia, mostly known by people, can be divided into two parts. Okay, thalassemia major and thalassemia carriers. Okay, a person who has thalassemia major has actually very reduced quality of life because these patients, they have to go for monthly blood transfusions. They have to eat a lot of medications per day. They have to live their life, spending their time at the hospitals to get the treatments done, to get their appointments going on, and their parents suffer as well. So thalassemia major reduces the quality of life by health and economical impacts. So actually, the best medicine doesn't lie in the syringe. Sometimes it just lies in the awareness that we can give to people. Okay, so our aims and objective is to develop a Thalia kit or the Thalassemia Education and Awareness Kit for private secondary school students, which can be delivered by medical personnel. And number two is to determine the validity of the Thalia kit itself. Okay, so thalassemia. Okay, thalassemia is actually the most common genetic blood disorder in our country. And according to the Malaysian Thalassemia Registry, we have that hundreds of new patients are registered every year, which is really appalling. And as you look at the number of deaths,
since the year 2014, it has not wavered at all, apart from being increasing all the way up to year 2023. So, sorry. Okay, and the most worrying part are the thalassemia carriers. Okay, so thalassemia major patients, you can see they're pale, they're frail, but thalassemia carriers, they look just as healthy as you and me. Okay, they do not have any symptoms. And as of right now, we have 2 million carriers residing in our country. So what are the odds? If you're a thalassemia carrier, you can easily meet another thalassemia carrier and you might end up together. So if 2 carriers marry, there is a 25% chance that they will get a child with thalassemia major, and this could lead to all sorts of problems. Okay, so the key to prevent thalassemia is to do a premarital thalassemia screening, which is you do a test before you get married to determine whether you carry the thalassemia genetic or not. But unlike HIV testing, it is not mandatory in our country. Okay, so the government actually acknowledges this problem, and they introduced the Thalassemia Prevention and Control Program back in 2016. So they introduced screening to secondary schools, especially those in public schools. But then they overlook those students that are enrolled in private institutions who are also equally at risk. And the irony is, these students that are enrolled in private institutions, they can afford screening, but they just don't know where and when to get the screening done. And also, despite all our national efforts, recent studies actually show that there is low thalassemia knowledge, especially among our young people in Malaysia. So we have identified this gap. We want to develop Thalia, which is the Thalassemia Education and Awareness Kit, directed to secondary students who are enrolled in private institutions. So for that, we use the original RD model. So this model is actually very famous to make educational interventions. We have analyzing, design, develop, implement, and then the last one will be evaluate. So for analyzing, we analyze 2 information. First is pre-existing information. We got it from online educational resources and even national thalassemia guidelines. And then we got new information from 8 different experts via modified therapy technique. And then as for the design part, we use the theory of planned behavior. Okay, so the theory of planned behavior is a very famous theory. What we did was we used all the existing information and new information, we fed them into the theory of planned behavior to come up with different contents for the Thalia kit. So next part is developing. So we decided to develop the Thalia kit by using all sorts of different materials. Some people will stick to only 1 material, but we decided to make 8. So we made a few PowerPoint presentations. We did our online videos, the short videos that you always see on TikTok. We also made comic books for the students and also a big poster for them to look up to. And then we also gave out guideline books so that we can tell them when, where to get screening done. And all these materials are available in both the English and Malay language via back-to-back translation. So, and then we decided to implement Thalia into a content validity and also a face validity. So we did a content validity among 9 experts using a 4-point relevance scale. And the scores that is needed should be 0.8 and above. For face validity, we did it among 30 students who are enrolled in religious private schools. I'm sure you've heard of Tahfiz schools. Yes, okay, so Tahfiz schools. All right. So the score for face validity should be 0.83 and above. So let's take a look at the results. Okay, so we have this, the content validity findings. What we saw is from the ICDI, all items actually met the minimum acceptable value of 0.78. Most of them scored 0.89, most of them also scored 1, okay? And then for the scale level content validity index, the score was 0.95, which was way over the 0.87 mark. And then we have face validity index. For IFPI, the scores actually range from 0.9 to 1. And for the scale level FPI, we found out that 96% of raters found that Thalia is actually clear, relevant, and also appropriate. Right, so moving on to the discussion. So what we found out is...
You have 2 minutes more.
Alright, thank you, Prof. So for the discussion part, okay, Thalia actually helps fill in the existing gaps we have in our educational programs. So first of all, Thalia follows a verified instructional design and also is theoretically grounded. And then we have multiple people from different backgrounds who collaborated to make Thalia. And also it is bilingual with very good cultural adaptation. Thalia is also present in both physical and also soft copies, where you can read it online on your tablet, or you can always open the comic book to read on the screening guidelines. And then it also has very strong validity. So we believe, with good faith, that Thalia can actually help increase knowledge, number one, instill good attitude, and finally instill good intentions to get screening done. So to conclude, all innovations has its limitations, including Thalia. So what we noticed is face validation was stayed among parents and teachers. Face validation was stayed among students. So we excluded parents and teachers, which are also very good important decision makers. And then no usability testing was done among healthcare workers to see whether they can use Thalia to give it out to students alike. And what we recommend is to integrate it into national preventive efforts, where we want to expand the use of Thalia not just to private secondary schools but to public schools as well. And then the way forward is we are planning to commercialize Thalia Kit, okay, and training to any interested medical practitioners or any interested healthcare personnel or the Ministry of Health, so that they can deliver Thalia to private secondary schools for an extra pocket money. Okay, and with that, I end my presentation. Thank you very much.
All right, thank you very much. That you struggled to keep to the 10 minutes time limit because it was a very active presentation with attempt to carry along the audience as much as possible, other participants. So are there questions or contributions for this awareness paper on a strange disease, so to say? All right, you can go ahead.
Hello? Okay, I would like to know how are you going to test the effectiveness of this Thalia kit?
Right. Thank you very much for the question. Okay, so we actually did part of the testing of the effectiveness of the Thalia kit. What we did was we did a cluster randomized control trial. So we picked out schools in Klang Valley, and then we clustered them according to different cluster characteristics, and then we randomized them into the intervention group and also the comparison group. So for the intervention group, we gave out Thalia. We delivered Thalia to the intervention group. For the comparison group, we gave out basic thalassemia education that was given to public schools in our country. And then we collected data by using a questionnaire. We tested their knowledge before and after. We tested their intention before and after. And then we also tested their attitudes towards thalassemia screening before and after. So the results are still being analyzed. So we don't have the results yet, but that is how we tested the effectiveness of the Thalia kit in Klang Valley.
All right. Thank you for that answer. When you spoke about your methodology, you said you used a 4-point relevance scale. Is that based on earlier studies? Usually, all these scales, especially ranking, they're usually odd numbers. Why is yours even? Or what happened exactly?
For the 4-point relevance scale, it's actually based on thalassemia questionnaire for content validity that is readily available and that was made in our country. So since I'm doing this study based on in our country for cultural perspectives and also because of studies perspective and population perspective, I use that 4-point relevance scale that is readily available in the Malaysian language and English language, which is suitable for the experts here in our country.
All right. And then I noticed that in your is it bar chart or histogram, that there was a lower death rate for thalassemia or thalassemia in 2022.
I'm sorry,
there was a lower death rate in your presentation in thalassemia for 2022. Have you tried to find out why there's that lower death rate in 2022?
In 2022.
Yeah, if you check your slides, it's there. Yeah, where you talked about the history of thalassemia and the way it affected the overall population. Anyway, I just want you to go and take a look, if you didn't look at it properly before, that there was a lower death rate in 2022 compared to the earlier year and then maybe 2023. Maybe there's a specific reason why there is a lower death rate there, but take a look at that later.
You mean a low knowledge in 2022?
No, lower death rates.
Low death rate in 2022. Okay, so according to the Malaysian Thalassemia Registry, 2022, usually when they put in the data, they put in backdated data. So before 2022 is 2021, right? Where our country and all the rest of the countries are, plagued by the COVID-19. So there was some discrepancies in putting in the data for thalassemia because they had to transfer out staff to help out with the pandemic. So I think that's why from the year 2020 to 2021, and 2022, the values are a bit lower compared to the other years, Professor.
All right, thank you very much for that presentation. We hope that you are able to move further with this awareness creation with
such presentations at conferences. So we look forward to you attending more quality of life conferences to give us updates on thalassemia. So we'll take the next presentation, which is on exploring changes in healthcare waste management post-COVID-19, a qualitative study in Maldivian health facility. How many presenters do we have for this paper? Do we have the international collaborator present or online?
No, I don't.
You don't. Okay. So you have 10 minutes.
Prof, can I
Yes, you can go ahead.
Assalamualaikum and a very good morning to everybody. My name is Fazila. I am a third year PhD student at the UITM, and today I'll be discussing about this paper. I'll be presenting the paper which I've done years back, and my co-authors will be Dr. Zamzaliza, who is also my supervisor, and Ms. Nazbia and Dr. Abdulaziz. So this it is exploring changes in healthcare waste management post-COVID-19, a qualitative study done in a modular healthcare facility. Outline and then the introduction of this is healthcare waste management. It is remained as a fundamental. It is a global concern for all the healthcare providers around the globe, and Maldives faces the same challenges as like any other small island nation face. The research aim is to explore healthcare waste management practices post-COVID-19 in a selected healthcare facility in the Maldives. Literature review: healthcare waste is the byproduct of as a result of healthcare activities from the healthcare providers, and it is generated usually within the hospital settings, clinicals, and healthcare laboratories and healthcare research institutions. And when the healthcare waste is improperly handled, the health risks to the people who are handling is very high, and also environmental damages occurs. The healthcare waste management, therefore, the healthcare waste management is a crucial and a fundamental activity for all the healthcare
facilities that provides healthcare services to the communities. The healthcare waste management is a process that includes waste generation, segregation, collection, treatment, storage, internal and external transportation, and disposal. Even though healthcare waste management is very wide, it is a very wide topic. However, I'll be discussing here only focusing to the health facility where I've conducted this research. The types of waste generated within the facility, it is usually two types, general waste, plastics. That consists of around approximately 85% of the total waste generated within the facility. And then biohazard waste includes infectious waste, pharmaceutical waste, chemical waste, and electronic waste. The remaining 15% consists of biohazardous waste. And this slide shows how a healthcare facility produces or increases, how healthcare waste generation increases its amount actually. There are certain factors like seasonal flus and outbreaks like COVID-19 that actually a lot of patients demand for health services. And then when the hospitals and healthcare facilities are overwhelmed, healthcare waste generation quantity increases. So one such example is COVID-19. During COVID-19 pandemic in Manila, 42 to 280 tons of infectious waste has been generated, and in Kuala Lumpur and Jakarta, around 35 to 210% tons per day increased, and in Bangkok, 27 to 160 tons per day, in Hanoi City in China, 26 to 150% tons according to ADP. And in this specific facility, the infectious waste generation has increased from 25 kg to 250 kg approximately per day. That is during COVID-19. And the methodology employed for this study was qualitative design, and the setting was the health facility. Study population was nurses and healthcare waste handlers in the facility, and convenient sampling from non-probability sampling was selected, and sampling size was actually total. Since it is a qualitative study, total number was participant was eight, which five were among 8, 5 were nurses, and the rest are waste handlers. And a semi-structured interview guide was used to conduct face-to-face in-depth interviews, and thematic analysis was followed. The researcher first went through all the data, qualitative data collected, codes and themes were formulated, and then later the themes were reviewed. After that, themes were named and defined, and then the report was generated. Ethical approval was obtained from before data collection from all the required institutions and the participants as well. Key findings. There are 3 findings we got from this study. The first was key changes to healthcare waste management practices since COVID-19 pandemic. Institutional changes. We found after COVID-19, the institutions have changed segregate waste at the point of waste generation, separate routes, and specific time for transporting healthcare waste. During on-site transportation and proper storage spaces, and designated vehicle which prior to COVID-19, we do not, the facility does not have one, and proper labeling, and then the organizational culture, leadership involvement.
Madam Fasila, you have about 3 minutes more.
Thank you, sir. Organizational culture, leadership and involvement and support have been identified, allocated focal point and regular financial support to conduct day-to-day activities. And these findings were consistent with the literature. And the second was major challenges in integrating healthcare waste management practices in the facility. Health training and education. Lack of training and awareness leads to health risks, to mixing wastes, and then when mixing all the wastes, the healthcare risk and environmental damages are high. Institutional challenges, limited spaces due to the nature of the infrastructure. As I mentioned, it's a very small health facility. And resource constraints, lack of SOPs and non-compliance. And these findings are also very consistent with the previous findings. The last finding was, is key interventions to improve healthcare waste management practices in the facility. Training and education. We found that training and education needed for the staff. So continuous in-house and on-the-job training, spread information through leaflets and posters, and trained staff who can observe and guide the staff who are handling with the waste. Policy guidelines, up-to-date policy guidelines and SOPs, which is also aligned with the institutional policies and the international guidelines is important. Resource availability, manage available spaces, treatment facility with proper equipment. So these are the key interventions that we recommended for the health facility. In conclusion, continuous staff education programs, proper guidelines and SOPs, and resource availability such as treatment options and storage space have been identified as key factors to improve. And the finding also highlights that a proper storage area coupled with treatment facilities to treat healthcare waste minimizes health risks while reducing the environmental impact of improper handling of waste. That's all about the presentation. Any questions?
All right. Thank you for that for this paper that addresses healthcare waste management post-COVID-19. Are there contributions or observations for the presenters? Okay, let me start by asking, because you said there's a need to treat healthcare waste, without, I just want to ask, what are the ways in which healthcare waste can be treated at the point of collection without environmental impacts?
Prof, can you repeat the question again?
Did you hear me? Because part of the suggestion is that healthcare waste should be treated at the point of collection. Apart from sorting them out into general waste, biohazard waste, and all that. Part of the paper says that it's good to treat at the point of collection. I'm just asking whether there are ways of treating this waste at the point of collection without environmental impact. Are there ways in which this has been done before?
treating the waste at the point of generation or at the point of collection? How we treat it?
Yes.
Okay, thank you for the question, Prof. At the point of waste generation, in the facility, after the COVID, they separate the waste, they segregate waste to different parts, and then wherever treatment is needed, it's only one treatment available in the facility at the time. So that is sterilizing. So whatever the waste can be sterilized, they sterilize before they take them to the collection point, and they do proper labeling and packing. That's how they do the process.
Oh, okay. That means that I'm like taking you out of your study right now. Maybe you are still going to do some study on all these treatment options that have little or no environmental impact, maybe much later. So what are you going to do next in this line of study of waste management?
I didn't get you. I didn't get it.
Okay, you didn't get it. All right. I'm saying that after this study, that is an exploration, what is going to be your next study? Since this is just exploration.
The next study.
Yes, after this.
The next step of this study. Okay. The next step, actually, I have already disseminated this study to the institution, where they can utilize this study as a reference material while they develop guidelines and SOPs. So, yes, that was it.
Okay, so dissemination is next. All right, but because it's an exploration, I thought that you were going to have a specific study, that makes use of this exploration. Maybe you can think about that, as the next place, the next study beyond, just making people aware that you have done this study. Do we have any other contributions or questions for the authors of this paper? All right, if there's no other question or contribution, let's appreciate them for doing something on healthcare waste management post-COVID-19. And we look forward to seeing you at the next conference. Thank you. So we'll take the next presentation that's on factors influencing healthcare professionals' knowledge, attitude, and self-efficacy in cardiopulmonary resuscitation, CPR, a systematic review. There's going to be one presenter. Are you the only presenter?
Yes, I'm the one.
Is your international collaborator online or present?
No, I'm alone.
You're alone. Okay. Thank you. You have 10 minutes.
To the excellent paper, fellow researcher and this progress, I am Hassan. Today I am honored to present the factor influencing healthcare professional knowledge, attitude, and self-efficacy in cardiopulmonary resuscitation. And this study collaborated with my supervisor, Dr. Cindy Kozama, and my another partner, Daphne Aminah Nigeria. Okay.
mean the leading cause for the premature death globally, affecting 500,000 individuals annually, particularly to adults aged 30 to 70 years old. So the CPR is the vital intervention to maintain the airway, breathing, and circulation for the cardiac arrest. And CPR, the intervention without any advanced medical treatment, need to perform during 4 to 6 minutes to prevent the physiological death. Okay. Sorry.
Bawah. Bawah.
Okay. Okay. Despite CPR is important, many of healthcare professionals lack adequate knowledge, positive attitude, and positive self-efficacy in performing the CPR. The study in Poland showed that only 37.5% of healthcare professionals know the correct compression during chest compression, and study in India showed that only 22.9% of healthcare professionals pass the basic life support training test, and only 10.8% know the correct response, and 24.5% know the appropriate action when facing cardiac arrest. And the gap for the positive attitude is inadequate training, fear of non-functioning of AED. AED is automated external defibrillator, and fear of communicable disease. And these two factors influence to the negative self-efficacy. So this study is, the objective of this study is to determine the level of knowledge, the level of attitude, self-efficacy, and factor influencing the healthcare professional in performing CPR. So, to conduct this study, I'm using the PRISMA guideline and PICO guideline. A total 63 articles have been identified, and through the database, PubMed, Web of Science, Medline, Google Scholar, and Scopus. Based on inclusion criteria justification, 40 articles has been identified and has been analyzed for the quality appraisal. So, 6 of the articles, they have a high quality study with the score more than 80%, and 5 articles, 5 of the study with the scoring between 60 to 80%. There was a medium quality study, and rest 3 study with the scoring less than 60%. That is categorized as a low quality study. So, the findings show that significant variation across the country, Asia and African. Out of 9 countries, Malaysia showed the highest in good knowledge. The result was 89.5% of Malaysian healthcare professionals, they have good knowledge about the CPR, followed by Indonesia, 78.1%, and can see here, Saudi Arabia, they have high moderate knowledge with the percentage 61.3%, and in contrast with poor knowledge was Ethiopia, percentage is 74.9%. So the key factor influencing the knowledge among healthcare professionals was work experience, age, training, basic life support, access to CPR information or guideline, practice experience, specialty area, governance factor, educational level, time elapsing the last season of basic life support training, a number of work, and exposure to the cardiac arrest. For the positive attitude, can observe in country Pakistan, Ethiopia, and Namibia. But surprising, one study at Pakistan by Shah 2022 that show only 30% of healthcare workers will do the CPR but involuntary, and 60% of healthcare workers not perform the CPR when facing the cardiac arrest. And the factor influence the attitude among the healthcare professional was CPR training, job designation, age, time elapsing the last CPR session attend, and reading CPR guideline. And last but not least, about the self-efficacy,
positive self-efficacy can observe in countries Saudi Arabia and Indonesia. So the factor influence the healthcare worker regarding to perform the CPR, what the self-efficacy was age, year of experience, number of managed cardiac arrest cause cases, and knowledge. Okay. For the discussion, enhancing CPR competency will recommend for regular training. By regular training such as hands-on simulation training for the real-life emergency can build the skill and confidence among healthcare professionals and need to update the CPR protocol time to time for the informal practice, and regular audit and regular assessment is good to identify and to address the competency gaps among the healthcare professional, and supportive environment is important to encourage continual learning and can foster the positive communication can foster open communication and positive attitude among healthcare professional. And last but not least is integrate the CPR curriculum in the healthcare education for consistent of reinforcement, knowledge, attitude, and self-efficacy. So as a conclusion, improving CPR performance globally is needed due to inconsistent of CPR scale with a variable of knowledge and attitude. By promoting the experiential learning such as simulation based training, this can increase the positive self-efficacy among healthcare professionals. And we need to address the negative attitude among healthcare professionals to build the confidence and readiness for them to perform the CPR. And regular refresher course is important to sustain the knowledge and confidence among healthcare professionals. And last but not least, hands-on training. Hands-on training is for the effective and skill enhancement. So I hope based by implementation of this strategy can standardize the CPR training and can improve the CPR outcome by consistently the knowledge and attitude, and can drive the confidence and self-efficacy among healthcare professionals for the effective CPR performance. Okay, that's all from me. This is list of reference for this presentation. Open the floor for Q&A. Thank you for it.
All right. Thank you for that presentation. That took just 10 minutes. Do we have questions or contributions or observations for the authors from other participants? Okay. Now I have one question for you. You talked about knowledge, attitude, and self-efficacy as the group of factors. So from this systematic review, which one is perhaps the strongest influencing factor?
Sorry, Prof, I can't hear you.
Okay. You have three groups of factors influencing healthcare professionals' knowledge, attitude, and self-efficacy. Which is the strongest factor? Which is the most important factor?
Oh, which is the important? The
most important.
The most important is attitude. Whether the person they have the knowledge, if they don't have the positive attitude to perform the CPR, they just let the patient go. The important is we have to gain the attitude, positive attitude to perform the CPR among not only among healthcare professionals. Actually, CPR is because CPR is critical role for the cardiac arrest. We suppose we can gain the positive attitude for everybody if facing for cardiac arrest.
All right. This study about, is it possible to do more studies on this matter of attitude then? Because there might be other things that, what are the things that really affect the attitudes? That could it be cultural or some other factors that are like related to the humanities much more than knowledge? No, I'm just trying to like x-ray more what can affect attitudes. Or maybe I should ask you, what is the next phase of research you want to do after this systematic review?
Okay, you asked me when for next study about the attitude.
Yeah.
Okay, if for the, I will explore the barrier to retain the positive attitude and for the knowledge retainment and for the knowledge retainment.
Okay, because most likely, you know, as health professionals, they will have had the knowledge of it. They must have gone through a lot of training on it.
Yes.
But like you said, there might be some very human factors or communal factors or some other factors that is explaining their attitudes to really apply the knowledge that they already have. Maybe it's a good area for you to explore more, you know, about these attitude things. The other question is, well, you didn't do any research on ordinary people knowing about CPR, people that are not healthcare professionals. Maybe we need to look into that too. People that are not healthcare professionals, you know, what can be their, what can determine their knowledge, their attitude, and efficacy to non-healthcare professionals. So I'm just suggesting.
Suggested. Actually, if you research, I mean, we look for the study, a lot of study done for about the CPR, but very rare in sense of healthcare professional role. And some more, to me, healthcare professional is like lead by example. Healthcare professional need to give the good, I mean, example to the family. That is very important. You ask again?
No, I said, are there any other contributions from the other participants? Conference? Yes. Okay, if there's none, thank you very much for that presentation.
Let's take the next presentation then.
Which I think is the last one for this session, is comparison and agreement of LDLC formulae in cardiovascular risk stratification among Malaysians. So, is the presenter here?
Okay.
Okay, I will start. Okay, Assalamualaikum. Sorry, I'm the last presenter. Okay, inshallah, I will try to make my time up to 10 minutes, inshallah. Okay, I'm Elise, Elisa Muhammad Kasim. I'm from Cardiovascular Advancement and Research Excellence Institute, University Technology Mara. Together with me online, as I mentioned before, Dr. AQoL from Indonesia. So, title of my research project is Comparison and Agreement of LDLC formula in cardiovascular risk stratifications among Malaysians. Okay, so before I go further,
Prof, can you see the slides moving? Prof?
Yes, I can. It's okay. It's just that I know it's coming up slowly.
so and also to the again, why is LDLC matters? So LDLC, also known as a layman as a bad cholesterol. The good one we call it HDL, but here I'm focused on the bad cholesterol, which is known as LDLC. So why does it matter? From WHO 2023 reported that cardiovascular disease is #1 killer worldwide. And this is data from our previous study, which shows that LDLC is the most common significant risk factor, significant coronary risk factor for premature coronary artery disease. And how do we measure LDLC? We measure it through a formula. It's an equation. It's an equation-derived results. It's not directly through reagent. So the equation, we call it as a Fried-Wald equation, where as tabulated there, the LDLC is equal to total cholesterol minus the good one, HDL cholesterol, minus VLDL, represented by triglyceride divided by 2.2. However, this Fried-Wald equation has its own limitation. It cannot measure when your triglyceride more than 4.5. So for those who have hypertriglyceridemia, for example, when your triglyceride at the level of 5, we are unable to report your LDL-C value. So because of this, it may cause an inaccurate LDL-C value. So when there is an inaccurate LDL results, it can lead to underestimation or overestimation of LDL. What we worry is about underestimation of LDL-C value. Patient may not know that actually they have hypercholesterolemia, and therefore there is no lifestyle changes. Patients do not adhere to the medication, they don't seek treatment, and they continue with a high-fat diet, sedentary lifestyle, continue smoking, and this LDL-C will be circulating in their bodies and lead to coronary artery disease. Therefore, this brings to our research objective, where we want to compare the performance and agreement of various LDL-C calculated formula, and also we want to quantify the extent of patient reclassification. We need to say here coronary risk classification when Fried-Wald is used as the reference. Okay, so how reliable is the current Fried-Wald equation? At the moment, LDL-C measurement, we can measure through direct method and also indirect method. When we say direct method, we need to say we have specific reagent and we say, however, it is not widely available, it is costly and it's tedious in the laboratory, not only in the routine laboratory, in fact, the research lab will also take time and consume more cost. What we adopt is the indirect method, whereby the LDL-C formula, where the LDL-C result is derived from formula. The current one is we are using is the Fried-Wald equation, the one that I showed earlier. However, nowadays there's an emerging formula. For example, Martin-Markins. This formula has been endorsed in ACC, Asia, in the United States, and validated across Brazil, South Africa, and some area in Europe, and also part of Asia. Other equation is sensor equation, and this is has been adopted by Polish Laboratory Society and validation studies in China and Turkey. The other one is Entandaraja. This one has been studied in Brazil, Greece, Serbia. However, it shows this is research. So from here you can see there is other emerging formula apart from Fried-Wald equation that are used to make the LDL-C value more accurate. So how we conduct the study? We use a method retrospective cross-sectional study population. We use MyHebat database. MyHebat is a project whereby actually we did a screening throughout Malaysia, including Sabah and Sarawak. Up to now, we have we are reaching about 6,000 total populations, and where we took demographic data, anthropometric measurement, and also lipid profile data. With this lipid profile data, we then run the LDL-C equation. So we run for Fried-Wald equation, Martin-Markins, Sampson, and also Entandaraja. Then we take the mean of this analysis of this LDL and then we compare the result through ANOVA. We use blend argument to measure the improvement, and then we also redo the reclassification using clinical categories according to NCEP 80P3 guideline. So what are our findings? So throughout this about 6,000 data population, most of the participants females, about 60.1%, and they are non-smokers. The mean age is about 42, and they are at the range of overweight. They are not hypertensive, and the lipid profile is about borderline high. And not most of them, about less than 12% having diabetes, hypertension, also hypercholesterolemia. Okay, for this agreement, we noted that among all these three equations, Samson, Martin Hopkins, and below there is Ananda Raja, Samson shows the best agreement, good overall agreement. However, we need to interpret cautionly at the low LDL value. For the Martin Hopkins, we can say it has a fairly good agreement. However, it slightly overestimates LDL-C at low level. While the Ananda Raja, it has a very wide scattered data. You can see that it has higher variability across LDL-C values. Overall, comparing all these three equations, we can conclude, we can say that Samson has the best agreement when we compare with the firewall equation.
You have 2 minutes more.
So this is another result where we want to show when we reclassify of LDL-C according to NCEP 80P3, we found that firewall equation shows near optimal value. When we do this heat map analysis, it shows that the firewall has a better agreement, about 56.7%, and there was an agreement by Samsung, which shows 53.6%. So in conclusion, Samson's, no doubt, is a newer equation. It's been developed around 2020. It shows the highest performance and improvement, and it also shows highest misclassification of LDL-C category relative to the firewall equation. However, the limitation of this study is that we are not comparing the LDL-C data with the direct LDL, with the ultra-centrifugation method, which is actually the gold standard method for measurement of LDL-C. So, for future direction, we think that there should be a consensus to adopt to measure this LDL-C accurately, whether through direct method or through the indirect method. Probably we need organizations or anybody to start measuring our LDL by doing our local formulation data. I think that's all. With that, I thank you.
So, thank you very much for that highly technical presentation on cardiovascular health. And do we have contributions from the audience or from other participants or questions? I have a question as an outsider. You know, you were doing, I know that some of this has to do with cholesterol. And there's always this talk about what constitutes healthy cholesterol and what is unhealthy cholesterol. Is it true? Or what is the state of knowledge in what is healthy and what is unhealthy cholesterol?
I hope I receive your question correctly. You asked me how do I collect the data and then how do I receive the funding. Am I right?
No, no, no. I'm just seeking an interpretation, whether this your study has to do with whether cholesterol is healthy or unhealthy in cardiovascular research. All right, let's leave that one. Maybe it is a little bit outside of your this thing. Let's start from your last conclusion. You said there's a need to adopt newer and more accurate LDL-C formula for hypertriglyceridemic individuals. Are there more newer formula?
At the moment, Prof, the sensor equation is the latest formula that we know been adopted. They've been studied it since 2020. That would be the latest formula for LDL-C calculations. There is no.
Okay, so was it part of this research, the newer formula?
Sorry, Prof? Yeah, that is considered a new formula. The sensor equation is a new formula and it's been developed since 2020. And it has been now still been validated and not been used widely.
Okay, the other one is the other conclusion that Samson has the highest performance and agreement. And it also has the highest misclassification of LDL-C category relative to Friday world. Is there something that can be done about this?
That is according to the ATP3 guideline. The one that I mean, the one it shows in the slides is according to the.
Yes. In the conclusion, your last slide. Your last slide shows that Samson has the highest performance and agreement. And it also has the highest misclassification relative to Friday world. I said, is there something that can be done about that?
Yeah, even though it shows highest performance and agreement with FrightWall, what does it mean? What it means here by misclassification is that some of the data which shows is fall into higher risk category. Is higher risk category. So let's say if a FrightWall equation for when patient use a FrightWall equation, they will classify according. They will classify in for example normal LDL-C. But when you use Samson, it will show you towards a higher risk group. It probably become borderline groups. That's what it's meant by highest misclassification of the LDL-C category. I hope I answered that.
Okay, sorry. The implication is that you will have to be using many formulae for each time that some kind of assessment is being done.
Yeah, in future we probably need to follow our population based LDL so that it will accurate and reflects our populations.
All right. So what is the next level in your research now? What are you doing after this?
Oh, okay. Asking for more funding, Prof. because population study need more funding because like this one you can see that it's a 6,000 data and it's begin since 2011. It's not a single year study. We need more funding and more collaboration and for this project it has started 10 years ago. We collect the data and I hope I can continue again with this population study and I plan to ask more funding from the government or other professionals' groups.
But you know that before you can ask for more funding, you must have the steps, more research, more lines of research. The future lines of research must be ready before funding can be granted. So you need to go ahead and think about the next levels of research you want to do. So at least you can now request for funding based on those lines of research.
Thank you for that presentation. Any other questions or contributions?
No, bro, thank you.
All right. If there's none, thank you very much for.
We appreciate all the presenters, and we wish you all the best in your next lines of research. And we hope that when you make progress with your research, you will still avail us the opportunity of having updates on your lines of research. So this brings us to the end of this session. So I hand over to Prof. I can see Professor Yusuf.
Hello, Prof. Where are you actually? I see coconut trees behind you.
Yeah, I wanted to simulate being on the beach also. Since you are in a beach resort.
By the way, it's seldom that you be the first breakout chair. What time is it now in Nigeria?
It is very early in the morning, 5:34 in the morning.
5:34. Oh, okay. That's not too early. I mean, that's nice for a change. Oh,
Yes.
by the way, we are working out with your colleagues to do it in Nigeria sometime in 2000 in next year. So hopefully we'll see you alive there.
Yes, that would be wonderful.
Right. Your colleagues are very eager, to bring the conference there. So I told him, let's try to work something for 2026. So hope to see you
All
there
right.
live.
All
Thanks
right,
again.
that would be good.
Very sorry to disturb your sleeping time.
No problem.
Right. See you then, Prof.
All right.
Thanks.
All right, thank you.
Over to you, Adib.
Okay, thank you, Prof. Babatunde, for chairing the first breakout session. Can we give a round of applause?
Thank you.
Okay, thank you so much, Prof. I hope you enjoy your lunch, breakfast. I don't know the time of the day,
All right.
Okay, hopefully we see you. Hopefully we see you next year. Thank you so much. Okay, hopefully we see you next year in Nigeria, inshallah.
Of course, I'm looking forward to that.
Inshallah. Okay. Thank you, Prof.
Bye now.
Okay, bye.
Take care.
You too. Okay, so the photo session, first we will have it and the other will be at Zoom. The photo session, the group photo session. So, you can. Tapi sebenarnya tu tunggu Prof dulu. Hah?